Yep.
Okay. So my name is Tyler. I'm your professor for ophthalmology. I am a physician assistant currently working in ophthalmology. So that's my daily field. So I have a lot of experience with ophthalmology and the ins and outs of the eye and things around the eye. My kind of daily role, if you will, I'll tell you guys, I see a lot of post-op patients after cataract surgery. I help a lot with glaucoma, diabetes, um, refractive surgeries, lasers, a whole slew of different things, a lot of dry eye. So I kind of have a comprehensive ophthalmology role right now. I don't deal as much in the retina, but I still see the retina all the time. And anything that pops up in there, of course, we treat it and then we refer usually to our retina colleagues who have a little more expertise and the tools to fix things back there. But I do have a really good background in all of ophthalmology so far. So I'm going to get going with the slides here if you guys are ready. Just let me know if you could see it when I pull it up. They did share the slides with you guys, correct?
Yep, we have access.
Perfect. And actually, before I do the slides, I'm going to put my email in the chat for you guys. If you need anything, if you have any questions, do let me know. Also, I don't know how far out for a schedule they have given you already, but I was planning for before your final to do about a 2 hour kind of Q&A. Doesn't have to be 2 hours, but I'll just be available for 2 hours, like a little Q&A before the final. So if you have any questions or anything that you want to go over, any topics that have been unclear, uh, you can always ask me at that time too. But feel free to email in the meantime. But right before the final bring any questions that you have to that little Q&A. Now, the administrators of Toro, they said that I can't run a designated review session, but I can be available to clarify any questions you have. So bring any questions, any topics, any concerns you have, and I can answer them at that time too. So that'll be right before the final. I'm going to give you guys my email here. I'm going to give you my regular email as well as my Toro email. You feel free to email either one. To be honest with you, I probably will look at the regular email first, but I should still be seeing the Toro ones as well. So feel free to email either one, but I'll give you both. Okay. All right. Now, I can't see all of you guys, so just feel free to, unmute and shout out if you have a question as we go along. Can you see the slides here that I'm presenting?
Yes.
Oh, good. Thank you. Let's get this out of the way. And okay. So starting off, this is our first PowerPoint for ophthalmology. The other ones I am going to update as we go through this next week or so and have them to you guys before we start the next lecture. But this is the only one that we're going to go through for today. So starting off on our first slide here, we have the bones of the orbit. Now, of course, this is not an anatomy class. I'll be upfront with you guys. We're not testing on, point to this bone, what's this bone? That's not what we're doing here. Now we're getting more into your clinical scenarios at this point in your didactic year. So it's not just, cut and dry anatomy. What's this bone? What's this vessel? What's this innervated by? That's not the types of questions you guys are going to be getting asked anymore. I could say that specifically for here, but also in your general PA didactic year. That's not what's going to be going on anymore. So you have to really start thinking clinically, think about your base medical knowledge, and apply that to clinical scenarios that you may be finding. Now, of course, these bones of the orbit, you always want to know them. It's, of course, going to be things that you're going to see on your rotations. For example, in the ER, you may see people that are coming and, they had some type of facial trauma. They got hit with a baseball in a baseball game. They got punched in a fight. They fell down and, cracked their head on a corner or something, on a desk. You may see them even at your geriatrics rotation. Falls are very common in the elderly population. One thing that I want you guys to know is that the most common fractured bone of the orbit is actually the maxillary bone here. Okay. Now, the next most common one is going to be the ethmoid. Now, although the ethmoid is not the most commonly fractured, the cool part about the ethmoid is that you don't often have to repair it. You could just usually leave it alone. It'll eventually heal all on its own. You don't have to really do anything for the ethmoid fractures most of the time. But the most commonly fractured bone is going to be your maxilla. So just familiarize yourself with the orbit, how things are looking and attaching. But again, the questions that we're going to be asking here are not going to be just cut and dry anatomy questions. We're going to be applying this information to clinical scenarios. Now, getting into our extraocular muscles. These ones are going to come up on, things that you see in rotations, in testing scenarios, on your pants. This is things that are going to come up. So you want to always make sure you're remembering your extraocular muscles, how they're working. So there's four what we call rectus muscles, and they're going to just pull right towards the direction that attachment is. So for example, the superior rectus here, if you follow my cursor, will just pull the eyeball straight up. It'll get your pupil looking more up, and you're going to be seeing more upwards in your vision. Then there's two oblique muscles, and those are kind of like a pulley system. And I have a little bit better picture on the next slide to show you, but that pulley system makes the eye move opposite from the way it's pulling, almost on like a torsional type of force, going back and forth on a rotation, if you will. So here we have a little bit more clear picture of the extraocular muscles and their functions. So again, superior rectus, we're going to pull the eye straight up. Lateral rectus, medial rectus. Lateral is going to pull temporally, medial is going to pull nasally. Inferior rectus, of course, pulling down. Our inferior oblique here, you could see that as that pulls, it's going to be twisting the eye counterclockwise if you're looking at the eyeball. So that's why this little black line is going to that arrow. So it's on a pulley system and it's pulling it opposite of the way it's attached. Same thing with the superior oblique. Again, it's pulling on a little bit of a torsional force. So that is going to allow you to look up to your corners of your gaze when they start working together. For example, if you want to look up and to the right, you're not going to be using just the superior rectus. You're not going to be using just the lateral rectus. The muscles start to work all together. You're going to start using some obliques as well to twist the eye and tilt the eye in the same direction that you want to be looking. So all the muscles are going to be working together. Okay. Now, there are six cardinal fields of gaze. This is something that you guys should definitely know because this is something that you're going to see on your rotations. You might see, for example, in pediatrics, a child with, what we commonly might call a lazy eye. And the doctor may ask you, what kind of deficits they may be having in their field of view. So, for example, the muscles that we want to be working together. If you want to look to the right and up, it's going to be the right superior rectus, the left inferior oblique. If you want to look just straight to the right, so you want to look, for example, to your right shoulder, or just straight out to the right, you're going to be using the right lateral rectus and the left medial rectus. So again, if we look back at our picture here with the muscles, you could see that each eye has the same set of muscles. But if you want to be looking to the right, of course, the lateral rectus will be pulling for the right eye, but the medial rectus will be pulling for the left eye. And you could see that of course, muscles would be flipped for the other eye. So this is all a right eye view here. So if we were looking at the right eye specifically and you wanted to look right, your lateral rectus for the right eye will be pulling. But if this was a picture of the left eye, this would say medial rectus. So the eyes are going to move together and you just have to think about which way the muscles are pulling and looking. So again, if you're just going to look straight to the right, the muscles that are going to be working in your eyes is going to be your right lateral rectus and your left medial rectus. If you want to look right and down, your right inferior, left superior oblique. Left and up is going to be your left superior rectus and the right inferior oblique. And again, left, just looking straight to the left, 90 degrees left. You're going to be using the left lateral rectus to pull the left eye outwards and the right medial rectus to pull the right eye inwards and keep the eyes lined up with each other. And then, of course, left and down, you're going to be using the left inferior rectus and the right superior oblique. So this is something that you guys should know. Try and memorize this for when you're going out to your rotations. It's something that you could definitely use. Now, our lid muscles here. Sorry, I just want to go one slide back here and talk about the muscles for just one more second. When we're also looking at the fractures, remember I told you we want to apply things clinically, right? So, for example, if you have someone who got hit in the face with a baseball and they're trying to look upwards and they're having what's called diplopia, they're having double vision. That's what we call double vision, is diplopia. And you can see that their left eye, when they're trying to look upwards, is not going, but the right eye goes up just fine. That means that one of those muscles are entrapped. So, for example, you might have an entrapment of the inferior rectus in that scenario because this muscle is stuck. So that means no matter how hard the superior rectus may be pulling, if you had like a fractured maxilla and your inferior rectus was trapped on that snapped bone, then of course the eye won't be able to move up. So again, we just want to make sure we're thinking clinically that although this is how the muscles are working together to give us our fields of view, we want to think clinically and say, all right, if something were to be messed up, if we had a cranial nerve problem, some type of nerve palsy, or if we had a broken orbit bone and there's maybe an entrapment, how are things going to differ? And that's something you want to definitely make sure you remember, is especially things like those entrapments or nerve palsies. And we'll talk a little bit more about that in the future. Now, the lid muscles. So you have your orbicularis oculi. It's a sphincter muscle that helps close the lid. It's going to be innervated by cranial nerve 7. So like a circular kind of muscle around the eye. Okay. The levator palpebrae. It's a retractor muscle that opens the lid. That's going to be innervated by cranial nerve 3. So 3 is going to open the eye. 7 is going to close the eye. Okay, that's a nice little picture here. Now, one thing that may come up in some of your rotations, you may see something that's called ptosis, for example. And ptosis is when the eyelids are not able to fully open for some reason. Now, there's a few different reasons of ptosis, but for example, the levator muscle here, the opening muscle, sometimes we can have what's called the levator dehiscence, meaning that the muscle has ripped away from its attachment. So although the muscle may be retracting and flexing, there's no attachment point to the lid, and it's not pulling the lid appropriately to go up because that levator muscle has dehisced, we call it. So a levator dehiscence would cause what we would know as a muscular ptosis. There is another type of ptosis that's related to a condition called dermatochalasis, and this is not on the slide, but dermatochalasis is like extra skin, for example. And I'm sure you've seen this in people that you've met before, especially in the older population. Dermatochalasis is just that extra hooding of the skin, and that's not muscular. That's just extra skin, and it's just causing a mass effect that pushes the eyelid down because there's just so much extra loose skin there. So those are two different types of ptosis. It could be from dermatochalasis, which again is just the extra skin, or it could be related to the levator palpebrae muscle, and that's a muscular ptosis. So there's two different types of ptosis, and we'll talk a little more about ptosis in the future, but that is a good point I want you guys to remember, is that there's multiple types of ptosis, and of course, there's different ways to treat those ptosises. For example, if you had a levator dehiscence, you can get a surgeon to reattach that muscle appropriately. If you have what was called dermatochalasis, remember that extra skin, the hooding, you can get something called a blepharoplasty, where a surgeon will just cut off the extra skin and then just sew back up the rest of the skin. Usually they make their incision in the normal eyelid crease, and then that allows the eye to open up better. Now, I do have one photo that I can show you guys. If you give me one moment here, I'll show you an example of the blepharoplasty surgery. Let me stop sharing for a second. And I'm going to pull up the photo. Here's a good example. So I'm going to share the screen again and show you guys. So what we're looking at here is more so this photo here, not the rest of them as much. But you can see here, this is the hooding. This is the dermatochalasis that I'm talking about. So you can see there's just all this extra eyelid skin that's causing a little bit of a mass effect. And this one isn't very prominent, but you will see some examples on your patients where that extra skin, that hooding, pushes the eyelid down even in front of the pupil, and it really starts to block their vision. And that's when the insurance companies will agree to go forward with that blepharoplasty surgery. And here is more so an after. So if you were to cut all this extra away and just resew the pieces back together, now you have a nice normal looking eyelid, and it's easier for them to open their eye, easier for them to see. Okay. All right. Now we're back on the slides. Everyone can see the slides again. Is that correct?
Yep.
So moving forward now, we have our vascular supply. So there's always, of course, things you want to keep in mind. Of course, when you're going to places like the ER, or if you're on an ENT rotation, an ophthalmology rotation, which they do have if you guys are interested. You want to keep in mind your vascular supplies in cases of things like strokes or blood vessel blockages, central retinal vein occlusions, branched retinal vein occlusions, etc. So your vascular supply here, the internal carotid artery goes to the ophthalmic artery. Your major branches are going to be the central retinal artery, the posterior ciliary arteries, there's a short and a long, and your anterior ciliary arteries. Your venous drainage from the eye, you're going to have your central retinal vein, going to the superior ophthalmic vein, and then the cavernous sinus. Your inferior ophthalmic vein goes to the cavernous sinus and or the pterygoid venous plexus. No, the conjunctiva, that's our thin mucous membrane that's made of non-keratinized columnar cells. The conjunctiva is the clear skin of the eye. Okay, that's all over the eye, it's all over the inside of the eyelids. There's different parts that we call certain types of conjunctiva, but at the end of the day, I want you to just know the conjunctiva is the clear skin over the eye. You don't even see it unless you're really in ophthalmology and looking into it with the slit lamp, but it's the clear uppermost layer of skin over the eye and the eyelids. So again, we have our two parts. We have the palpebral conj, which lines the inner eyelids. So also known as the tarsal conjunctiva. The bulbar conjunctiva is the one that lies over the globe. These two meet each other at the over the conjunctival limbus. Okay. So we have a little bit of a picture here. So just so you could see, we have red boxes around the parts that we're talking about. So the fornix is the part of the eye that's everyone thinks you could start going behind the eye, and you can't. The fornix is a wraparound of the conjunctiva. So, for example, people can't really get contacts, for example, all the way in the back of their eye. That doesn't happen. It can get lost and stuck underneath in the fornix here. And this does go fairly deep, but it's not going to go all the way around to the back of the eyeball. So the fornix is you have, of course, a superior and an inferior. This is just the angle of where the palpebral conge, which you can see here if you follow the line, is the inner eyelid skin, changes into the bulbar conge, which you can see is the skin over the eyeball. Okay. So when someone has conjunctivitis, it's just an inflammatory response of this clear skin of the conjunctiva. Now, your lacrimal apparatus, of course, made up of a bunch of glands and ducts. You have your lacrimal gland, which we see over here. Your punctum, there's a superior and inferior. The puncta are the drains of the eye. You have one per eyelid. And if you pull down your own, for example, lower eyelid and look near the nasal corner, you'll see like a little bump on your eyelid with a little hole in it. That's the puncta. That's the drain. So you have one per eyelid that, of course, drain into the common lacrimal duct. And of course, again, this is not an anatomy class, but these do have clinical applications. If, for example, traumas or dry eye patients. One process that we like to do for dry eye patients is called punctal occlusion or punctal plugs. So we put little collagen plugs right into these drains and block them up purposefully to keep more tears on the eye at any given time, hopefully giving them less dryness, less discomfort, and better vision. So the globe, this is the eyeball. Okay. Now the eyeball is not a literal sphere shape. You can see there's different steepnesses at different parts of the eye. For example, the cornea, that has a different steepness to it than the rest of the eye. And that steepness, that shape, is what gives us our refraction. So when you're getting glasses, for example, the cornea and the lens work together to refract light and make it come and land back on your macula. When the cornea and the lens can't do enough refraction to hone in that light, that's when we start to need glasses and contacts, for example. So the cornea has the most steep curve. It's not a literal ball or sphere, and that's our refraction. That's how we bend light back to our macula to give us our vision. If the steepness of the cornea is abnormal, that's when we get the thing called astigmatism. And I'm sure you've all heard of it before if you've ever been to the eye doctor. A lot of people have astigmatism, a huge percent of the population. That's just when it's not a perfectly circular dome, if you will. Sometimes this steepness is more of a bow tie shape or it's more lopsided. So any abnormality in the corneal steepness is what gives us astigmatism, and that causes starbursts of lights or blurring of the vision. Okay. The sclera, that's about 80% of the globe's surface. There's three layers to it. The episclera is our outermost layer. Okay, so that's when you get a corneal abrasion. The episclera is the most common part that is damaged. You have the stroma, which is just made of dense fibrous tissue, and then the lamina fusca sclera. So that's loosely attached to the choroid, which is here. That's where you start getting all of your vascular supply and, of course, some of your inputs from the eye to the brain. But the episclera is all the way on the outside. Now, the cornea, that's meeting the sclera at limbus. So remember, the sclera is more of our white surface here of the eyeball. The sclera is all the whiteness, and this is still covered in conjunctiva, but the white of the eyeball is the sclera. The cornea, as we saw, is clear. That's our steepest part of the eye. So that's clear, and your iris is the colored part of the eye. This lens here, this is what's helping bend the light, but that's right behind the pupil. The pupil is a hole into the eye. So the pupil is not a physical structure. And that's something I need you guys to know because we get those calls from the ER all the time from, for example, PAs or nurses or NPs who aren't too familiar with the eye. They've just kind of, had brief interactions with the eye, and they'll say something is on the pupil, for example. It is not. The pupil is a hole. You cannot have something on the pupil. Things could be on the lens. Sometimes they call us and say that something's on the pupil when it's really on the cornea in front of the pupil. So that's just something I want you guys to understand when you go out into rotations so you don't sound silly. You can't have something on a hole. So the pupil is just a hole. That's the window into the eye. The cornea is our clear outermost layer. So again, we have different parts of the eye meeting at the limbus. So the limbus is just the margin right here that I'm moving with my cursor between the sclera, the cornea, and the iris. They all meet at one little part here, and that change in the eye is called the limbal margin. The cornea has 5 layers to it. Now, these are all clear. When you get a scratch, you're most commonly damaging the epithelium. So if you have a corneal abrasion, a foreign body, most of the time it's just damaging the epithelium. And we'll go over abrasions in a later lecture, but I just want you to know that the epithelium is the most common damaged layer in abrasions. And that's something that's important. I want you to put a star. The epithelium is your most common damaged layer. Now, the epithelium heals very fast, within 1 to 3 days, even for a severe abrasion. The epithelium heals remarkably quick. But if you cut deeper than the epithelium, you start getting the Bowman's layer and the stroma, for example, lacerations and cuts down through here. That's when it's really going to start to scar because the stroma is a lot more fibrous than the epithelium. So the epithelium oftentimes will heal and not leave any damage behind. But if you start getting into a lower part of the cornea, more into the meat of it, and even towards the in part of the eye, and if you went all the way through here, this would be a penetrating trauma. But if you got into the stroma, that's when you're going to start to have scars. Okay. But the epithelium, again, I want you to remember that's the most common damaged part for abrasions. So again, cornea, we already covered this, but it has 5 layers. The epithelium is the outermost that absorbs and distributes oxygen and nutrients from the tears. It's extremely sensitive. And of course, it's the most common location for corneal abrasion, star, star, star. So you will come up and see that on your rotations. Bowman's layer, again, is the next one down, made of collagen fibers. And again, once we start getting to Bowman's layer, and especially the stroma below that, it may scar as it starts to heal, and scars can cause vision loss. Stroma is 90% of the cornea. That's the real meat of the cornea, mostly made of water. It is avascular. Decimates membrane. It's a strong protective layer of collagen tissue. Damage here is repaired by endothelial cells, so more so inside the eye, and it can start to regenerate. One thing that I see in a lot of the post-ops after cataract surgery is called decimates folds. And that's when you're looking into the cornea and it all looks folded up like a wrinkled piece of paper. That's because there's so much swelling that it's moving around this decimates membrane and it's more easily seen because of that collagen tissue. And then the endothelium, it pumps out excess fluid from the stroma, keeps the cornea as clear as possible. But if it is destroyed, it will need a transplant. One of the conditions that we see very commonly with the endothelium is called Fuchs dystrophy, Fuchs, Fuchs dystrophy. And that's when we lose these pump cells that we're talking about here. So this pumping motion for all the fluid to get it out of the cornea is done by pump cells. And Fuchs dystrophy is a damage and loss of those pump cells. And when we lose enough of them, then we can't pump fluid out of the cornea and we start to retain water and we start to have blurry vision. It looks like you're underwater in a pool because you literally are. You're looking through water all the time. And if that continues, we may need a transplant. Okay, iris and pupil. Again, iris, the pigmented part of the eye. It's a diaphragm. It opens and closes. It's muscular. So it's not just a little layer of tissue that does nothing. The iris is a muscle. So it's going to contract and change its form to open or close your pupil, which again is just a hole, not a structure, but it opens and closes the pupil to give you more or less light. The pupil is between 1 to 8 millimeters in diameter, but 25% of the population have what we call anisocoria, where the pupils are different sizes on each side. Now, again, up to 25% of the population have that. It's usually less than a millimeter difference. But if you do notice it, you have to start to rule out your things like your cranial nerve palsies, your Horner's syndrome, or even your 80s tonic pupil. And I know you've heard some of these, especially in your PD lecture, but that's the things you want to start to look out for if you have anisocoria. Now, again, with 25% of the population having this in some type of way, not everyone's going to have those things like your palsies, your Horners, your 80s tonic pupil. They may just be anatomically like that. But when you find it in 25% of the population, again, you may find some of those other things. So you should at least keep your mind open to those other conditions. The chambers of the eye, we have our anterior and posterior segments. The anterior, which this is all right under the cornea. The anterior is from the cornea to the iris and the pupil, which again is just a hole. But the anterior chamber is from the cornea to the iris. The posterior chamber is from the iris to the lens. And the lens is in what we call a capsular bag. So it's from the iris to the posterior capsule, so just the back of the bag. Everything beyond that is the vitreous, the posterior part of the body. This is where our retina doctors come in more. This is their specialty, all back here. Now, this vitreous body, a little easier to start here. This is just jelly, if you will. So it gives us nourishment while we're in utero. Afterwards, it doesn't really do too much, just helps maintain the structure and the shape of the eye. But you can have, for example, it's called floaters. If some of this vitreous or this jelly breaks, it'll cause something called a floater or a posterior vitreous detachment. The way I like to think about the floaters coming from this vitreous is if you took a Jello cup, for example, and you were to put your spoon into the Jello and take it back out, you're still going to see that track of where the spoon went, right? Even though the Jello cup itself is still the same shape, you see where that damage happened. The same thing happens in the vitreous here. So if any of the jelly breaks, you'll see those breaks in the jelly because the light as it comes into the eye will be blocked by those little breaks in the jelly. And that means if the light is being blocked at the jelly break, it's not going to reach the retina. So you're going to see little black spots, little floaters. That's what those are. Anterior segment. This is where I mainly operate. Not operate as in surgery, but this is where I see most of my patients. The anterior chamber, the cornea, and then, of course, up to here, this is the lens. This is what becomes a cataract. We'll talk about that more later. But when we have cataract surgery, we take out this lens. So when I'm seeing them in post-op after my supervising physician does surgery, I'm checking out all of this here. So I'm checking in the anterior chamber, see if there's inflammation, white blood cells, if there's any fibrin, if there's any swelling in the cornea, and of course, if there's any damage to the iris or surrounding structures. Posterior chamber has aqueous humor, just like the anterior chamber. Again, just all up here, lens and up. So the anterior chamber, like we just said, the space between the cornea and the iris has aqueous humor, a clear fluid that nourishes and removes waste products. The anterior chamber maintains the shape and the pressure of the eye, and conditions that can affect the anterior chamber, like glaucoma, you've heard of, and uveitis. Now, the posterior chamber is the space located behind the iris, like we just said. It has the iris, the lens, the ciliary body that maintains the shape of the eye and allows light to pass through the retina. So again, this is all muscles here. These are the zonules. these little strings here. And as the muscles all around flex, they pull the zonules and they make the lens either get big or small, fat or thin. Sorry, didn't mean to do that. So again, the posterior chamber is providing a pathway for aqueous humor to circulate and then nourish the eye. The uvea, regulating light entry, again by flexing the muscles, pulling the zonules, and changing the iris shape as well. So it's highly vascularized, has a blood supply for the eye's inner layers, including the start of the retina. The pigmentary cells in the uvea absorb excess light. And they also have immune cells that help defend the eye against infections and inflammation. So when I'm looking into through the cornea at the anterior chamber and I see a bunch of white blood cell response, that's because the uvea has started that inflammatory response. So that's why some patients you may see have what's called uveitis or iritis. That's the same thing, uveitis and iritis, but it's an inflammation, an inflammatory response of the eye. The ciliary body has muscles that control the shape of the eye's lens. Again, we just talked about that with the zonules. And it also produces aqueous humor, which is the fluid that maintains the pressure and the shape of the cornea. So aqueous humor is formed by the ciliary process, fills the anterior chamber. It's clear, maintains our eye pressure, helps maintain the shape of the cornea, helps us focus light, provides nutrients, removes waste. And of course, again, as said, it has immunologic functions as well. So the pressure in the eye that is maintained by having the same amount of fluid come in as the same amount of fluid that is leaving the eye. So it's a constant production. You're making new fluid, 100% new fluid within the course of a day, sometimes multiple times throughout the day. So as you keep making new fluid, more fluid's being pushed out through what we call our pathways here. So there's a conventional pathway, aka the trabecular pathway, goes down through the trabecular meshwork and into the canal of Schlemm. The non-conventional pathway is the uveoscleral pathway. These work in conjunction with each other to keep that flow of fluid going consistently. We don't want to have fluid backing up in the eye because that's going to increase our pressure. And that increased pressure is what gets us to glaucoma. Increased pressure in the eye will put too much stress on the nerve in the back of the eye and it'll choke it out, if you will. So you can't have too much pressure on the nerve or it'll start to choke. And then you have nerve damage and vision loss. So our conventional pathway here, the trabecular meshwork in Schlemm's canal, is located in the anterior chamber. So the fluid is going to come up from over here by the ciliary body. It's going to pass by the lens, come out through the pupil, because again, the pupil is the hole, remember. It's going to come out through the pupil, circulate through the anterior chamber, and eventually it's going to push out over here through our angle, and then of course through the trabecular meshwork, which is just like a grate, if you will. It's a little drain, and then into Schlemm's canal and into the bloodstream. Okay. So that's vital in determining our pressure. When pressure is elevated more than 22 millimeters of mercury, glaucoma can result in have optic nerve damage. Our normal eye pressure is between about 8 and 22. So once you start getting up above this 22, that's when you really start worrying about the glaucoma and any long-term deficits. Now, glaucoma and nerve damage and vision loss, it's not going to happen overnight at a pressure of 23, for example. It takes a long time, it takes months or even years at that time, at that pressure to start to cause damage. But pressure is a scale, if you will. And the higher it goes, the faster damage can happen. So if you're in the 30s, for example, pressure could happen within a couple of days. If you're in the 40s or 50s, damage can happen within hours. If you're in the 60s, it could happen in minutes. So the pressure can really go up quickly, especially if you have what's called angle closure glaucoma. And I know you guys have definitely talked about that in PD. And that's when this angle right here that we're talking about closes and you don't have a way for any of this fluid to get to the Schlemm's canal. And it just starts building up and building up and building up, making it worse and worse and worse. And again, we have nowhere for the fluid to go, puts more and more pressure to the back of the eye and on the nerve. One thing that's a big cause of angle closure glaucoma or narrow angles is cataract development. So this lens, as cataracts develop, it gets thicker and bigger and pushes up and up and up against the iris, making this angle get thinner and thinner and thinner as the iris pushes more towards the cornea. So our non-conventional pathway, or again, remember the uveoscleral, is anterior to Schlemm's canal. There's only a little bit of fluid filtration that comes this way. So again, if you close off that Schlemm's canal, if you have the angle closure, that's going to be where most of your fluid goes. And that's where you get problems is when you close that. This uveoscleral pathway is another way for fluid to go, but it doesn't do as much as the conventional pathway. Ciliary muscle tone is going to determine this balance over here. And of course, if the ciliary muscle is relaxed, more fluid can release that way. Okay. So now we can see over here, we're going more towards the lens. And so the lens, it's a biconvex structure behind the iris. Again, also right behind the pupil. That's going to help focus our light, give us our vision. It's flexible, so it's not just a rigid piece of crystal. It's a flexible crystal, if you will. As we age, it becomes less and less flexible. That's when the cataracts are starting to develop. That less flexibility causes what we know as presbyopia. So by our 60s to our 80s, our lens loses the clarity. That's when it becomes a cataract. So the cataract is all of this together. The less flexibility, the loss of the clarity. This lens is avascular and is replaceable during cataract surgery. The biggest things that people are going to notice as they're developing cataracts is they're going to have decreased color vibrancy, decreased contrast, decreased vision overall. Things might look dirty, dusty to them. They're going to have increased glare because instead of it being crystal clear, it has a tint to it, that yellow brown tint, and loss of the clarity causes the light and especially headlights at night to start to scatter in the eye. That causes a lot of glare problems. The lens, as you're seeing and as the light is passing through that lens, it changes shape to give you the vision at the distance that you want. Sorry, I lost my words there. But if you have a fat lens, for example, if it puffs itself up, that's going to be magnifying things for up close vision. If you have more of a skinny lens, so if it's being pulled by the zonules and it's really starting to thin itself out, that's going to give you more of your distance lens, your distance vision. When presbyopia starts happening, the lens gets a little more stuck in the skinny position. So you start to lose your up close vision. And that's why you have to see your parents or your grandparents, depending how old your family members are. That's why you have to start seeing them putting their phone farther away from their face because they're getting presbyopic. So they're losing their up close vision. Their lens can't flex as much as it used to. So they're keeping more of the distance vision. They're losing that up close vision. That's why they have to put their phones out 100 feet from their face and everyone makes fun of them. It's because they can't see it up close anymore. The lens won't flex to be like that anymore. And that's why, of course, as the cataract continues to develop, that's why they have to put their phone on, 100 brightness when they're at the restaurant with the flashlight and embarrass everyone at the table. And everyone makes fun of them again. But again, that discoloration of the lens with the cataract means they can't see it as easily. So they can't see it up close. They can't see the contrast of the letters on the background. That's what's happening with the cataracts. And that's now you know what's happening to your parents and your family members as they're aging is the cataracts are developing, they're becoming presbyopic, they're losing their vision. Now, our vitreous chamber behind the lens, or we already talked about this quickly, the jelly in the back of the eye. It's two-thirds of the eye's body, if you will, filled with vitreous humor. So vitreous humor is jelly. Okay. The retina is the posterior border of the vitreous chamber, and that is something I want you to know. So the posterior border of the vitreous chamber is the retina. Okay. So the vitreous humor is different from aqueous humor. It's more firm and gel-like, again, kind of like Jello, if you will. Helps hold the retina in place. And again, the retina is our posterior border of the vitreous chamber. It's connected to the retina at the periphery, so there's attachments of the jelly all over. But again, if you have breaks or detachments of that jelly, that's when you start to get floaters. So it's connected to the retina at the periphery, the macula, and the optic disc. It's not continually replenished. Anything that gets in must be surgically removed. So the floaters, for example, they may float to the bottom of the eye very, very slowly, and you may stop noticing them as much. But if they become a real impairment and an impediment to life tasks, then we just have to vacuum it out because it's not going to go anywhere. It's not being cycled through. And again, like I said earlier, floatos are shadows of the clumps in that jelly. As we age, the vitreous can continually shrink and pull away, and it could even cause a retinal tear, so a big hole in the retina. It could even cause a retinal detachment if it pulls too hard, which is when that retina separates from the choroid, and then you lose all this vision here, and it needs to be put back down. Now we can tack it back down with lasers, we could use gas bubbles, different types of surgeries, but at the end of the day, just know that for this slide here, the vitreous humor is like a jelly. It attaches all over in the back. The retina is our posterior border to the vitreous chamber. And if the vitreous breaks or pulls away off the retina, it can make a retinal detachment or a retinal tear. I'm just going to have a drink of water. Excuse me for a second. Okay, so this is a look at the retina. This is our optic nerve coming in to the eye, coming back from the brain. So it all comes in here. And of course, all of your vasculature. Our macula here, this darker circle, is our where we get our central vision from. The fovea is the very central part of the macula, and that's where we're getting our 20/20 vision from. That most crisp central vision is the macula and specifically the fovea in the middle. The retina converts the light that we see into an electrical signal that's sent to the brain, and then the brain processes those signals and gives us our images. The retina here, the ganglion cell axons run to the brain via the optic nerve. They're, the ganglion cells are activated when light travels through them and it goes through the thickness of the retina and activates our rods and cones. The rods and cones are responsible for our color vision. And there's 10 layers of the retina. And again, this is not anatomy class. We're not going to be asking you to name the layers of the retina. It's just something to know. The retina has a bunch of different layers. It has rods and cones, and that stimulation of those rods and cones by light is what sends the electrical response to our brain to give us the vision. That's all. So our rods and cones, again, it's activated by light as it reflects back to them. The rods give us our light and our movement, responsible more for our peripheral vision, our night vision. It's activated more so in dark or scotopic conditions. Rhodopsin is the photopigment in the rods. Cones are responsible for our color vision. So C for C, cones for color. That's responsible for more of our color vision, our fine details, way more sensitive to the bright lights. So it's activated in photopic conditions. Iodopin is the photopigment in the cones. The macula, again, the center of the macula is the fovea. That's the absolute center of our vision. It only contains cones. So again, the cones, color vision, and detail. Responsible for processing and sending the visual information to the brain. Conditions that can affect the macula and therefore affect the vision, things like macular degeneration or even a macular retinal detachment. So again, macular degeneration, I'm sure everyone's heard of that. That's the big thing. As that macula degenerates, and we'll talk about that in another lecture, that's going to cause loss of the central vision. The optic disc, this is actually a blind spot. Everybody has a blind spot. Your brain just fills it in automatically. You don't have to think about it. It just fills in whatever you think should be there. And they have blind spot tests that you could even do on your phone as you move in, certain types of little dots or pictures close enough to your eye, your brain will just get rid of it because it doesn't know that the dot, for example, is different from the rest of the paper. You can do it with a paper, with your phone. There's blind spot tests online if you're interested and you want to just see something cool. But the optic disc is our blind spot. That's where the nerve fibers enter and exit the eye. That's where our central retinal artery comes in and retinal vein. It has a physiologic depression called the physiologic cup. And I'm sure you've heard in glaucoma, you may have talked about this in PD lecture, for example, the cup to disc ratio or CD ratio. That's what we're talking about is our cup to disc for, how big our cupping is compared to the overall look of the optic disc. Okay, so the optic nerve, cranial nerve 2, signals to the brain, allowing us to see. It's protected by CSF and meningeal covering, cushioned by fat. Signal is ultimately decoded in the occipital cortex. It's part of the central nervous tract. Other cranial nerves to know. Cranial nerve 3 is our ocular motor nerve, the extrinsic eye muscles, pupil dilation, the acronym that everyone remembers, LR6SO4. So lateral rectus is innervated by 6, superior oblique is innervated by 4. All of the other muscles are by cranial nerve 3. So remember that. That's important. You will see that come up on, things like your pants or be pimped about it on rotations. Your eye muscles, LR6. SO4. So lateral rectus controlled by cranial nerve 6, superior oblique by cranial nerve 4, all the other eye muscles, cranial nerve 3. Okay. Of course, you have your levator palpebrae superioris, you have your ciliary body, your iris sphincter, all controlled by cranial nerve 3. And like I just described, LR6SO4 a mnemonic to help remember the cranial nerve innervation of our muscles. Lateral rectus 6, superior oblique 4, everything else number 3. Other cranial nerves to remember, cranial nerve 5, your trigeminal, that's the sensation to the eye and the eyeball structures, the nasal mucosa, and the cutaneous areas around the eye. You have your 3 branches of the trigeminal nerve. That's going to be your V1, your V2, and your V3. And you can see here, V1 is going more towards the eye. The V1 is your ophthalmic branch. V2 is your maxillary, going more so under the eye and your cheek. V3 pretty much has nothing to do with the eye. The trigeminal nerve, just remember that the trigeminal nerve is responsible for feelings in the eye structures. So V1, our ophthalmic branch, again, that's sensation to our cornea, the conjunctiva. Remember, there's 2 types of the conjunctiva, the palpebral, the bulbar. You have your nasal mucosa getting feelings from here, your nose and scalp, frontal sinus, parts of the meninges. It's further broken down beyond the V1 branch. And again, we're not having you name the branches, but you should just know that if the V1 branch is affected, you're going to have sensation loss to everything in and around the eye. But of course, it can break down further, going to the inferior trochlear, the anterior ethmoid, etc., posterior ethmoid, lacrimal. V2, the maxillary sensation to the lower eyelid, the cheek, the nares, the upper lip, upper teeth, your gums, maxillary ethmoids, venous sinuses. So V1, V2 do have parts of the eye involved. V1 is the most. V2 again is more so the cheek and the eye and the lower eyelid. V3, nothing. Okay. Now cranial nerve 6, the abducens. This one is a big one. Remember, this is going to control our lateral rectus. And I've seen it a whole bunch of times in my role. I know I saw it on my ER rotation, a cranial nerve 6 palsy that's going to affect the eye muscles, most importantly, the lateral rectus. So remember, the lateral rectus is going to pull the eye laterally away from the nose. So if you have what's called a cranial nerve 6 palsy, or if you have damage to the cranial 6 nerve, that means that the innervation to the lateral rectus is going to stop. You're not going to have any more signal to the lateral rectus in a cranial nerve 6 palsy. When you don't have signal to the lateral rectus, it doesn't keep any muscular tension. And that means that the other muscle, remember the medial rectus on this eye, is going to be doing all the work. So that means it's going to pull the eye in because you have no nerve innervation to the lateral rectus anymore. So that's when you get something called esotropia. And we'll talk more about that later. But esotropia, that's when you have an inward deviating eye. The eye is going to go in towards the nerve if you have damage to the lateral rectus. So that's something that's very important. I do want you guys to know. You will see it with patients on your rotations. So again, damage or palsy of the cranial nerve 6, the abducens, you're going to lose your innervation to the lateral rectus muscle, and you're going to have esotropia, or the eye going inwards. Your facial nerve, that's going to control your facial expression, your eye closure, your taste, and also without thinking about it, it also helps you make tears in your tear glands, your salivary glands, etc. Now, getting into the actual eye exam, the history is the most important part of your eye exam. You really need to figure out what happened to these patients. It's important, but it's hard to obtain because eye complaints can be so vague and hard for them to describe. You have to try and really figure out, if it's pain, for example, is it pain on the surface of the eye? Does it feel like it's inside the eye? Does it feel like it's behind the eye? And that's something that is a big distinction. For example, a lot of people will come in telling me in an emergency type of visit, my eye's killing me, it's killing me. And I'll kind of deduce more, where is the pain coming from? Is it just feeling the front of the eye? Do they have a foreign body? Did they get something in there? Did they scratch it? Did they get a cut? If it's behind the eye, could even just be sinuses. And we've seen that plenty of times in our office where people come in, they're complaining of such bad eye pain, but it's really just a sinus infection. We give them a, short little burst of antibiotics and everything is right as rain. So you really want to have a good history, really get precise complaints out of your patients. What type of symptoms are they having? Can they describe the symptoms, characterize it, how long it's been happening, the course, and of course, anything that makes it better or worse. Is it only when you walk outside into a bright light? Is it when you're reading? Is it only when you're laying down? That's all things you really want to hone in on because that'll give you more of your story of what's really happening. You also want to make sure you find out if there's any vision problems. A big corneal abrasion over the front of the cornea right across the visual axis in front of the pupil, that may decrease their vision. If it's a cut, more so on the side of the nasal side, not so much in front of the visual axis, they might not have any vision problems. If they have a retinal detachment, for example, time is tissue because every minute that the retina is detached, you're losing your rods, your cones, etc., depending where the detachment is or the tear. And you want to really make sure you get them to a retina specialist very soon so that they can do a surgery to fix that and tack the retina back down. So that's where that, again, timing comes in. Was this happening for 20 minutes? Was this happening for 4 weeks? And that depends on, the court that leads us to different courses of action, should I say. Is it something that we have to bring them in right away? Is it something that we can wait? And it always comes up right at the end of the day. Someone comes in, they say, I have a lot of flashes, I have a lot of floaters, you know, uh, something like that. That's some of our key words, the flashes and floaters to things like retinal detachments, retinal tears. We'll bring them in right away. And then our technicians will get the history from them and be like, yeah, it's been going on for about 4 weeks. And we're like, all right, it's not that big of a deal. If you just had a whole bunch of flashes and floaters an hour ago, it's a bigger deal. And we're like, we wish you would have told us. So again, the timing is always key. You also want to find out if there's any non-eye symptoms. Is it vertigo, dizziness, headaches? That could be neurologic. Any constitutional symptoms. Your weight loss. If there's any rashes, scalp tenderness, they might not think of these things being related, but a lot of times they are. For example, they might have a rash across their face, and that could be shingles coming across to their nose, and they might think nothing of it, but it does relate to the eye. So you'll want to get all of your history correct. If there's any problems with the vision, if there's any other problems in the body, see if there's anything related. We see a lot of patients with thyroid eye disease. They may have a lot of constitutional symptoms related to the thyroid, rheumatoid arthritis, a lot of pain, a lot of flare-ups in other parts of the body. That could be leading us to having episcleritis, for example, or recurrent iritis or uveitis. Remember, those are the same, iritis, uveitis. Recurrent bouts of iritis and uveitis without underlying causes is rare. So if it keeps coming up and there's no real reason, that could be rheumatoid arthritis or, other type of autoimmune disorders. So again, we want to make sure we have a good history of the whole patient, everything that's going on in the eye, and of course, aside from the eye as well. Find out when their last eye exam was, if they use glasses or not, or even medications they use. For example, someone again with rheumatoid arthritis, they may be using Plaquenil or hydroxychloroquine. That can cause a retinal toxicity, specifically in the macula. And with persistent use, it can cause vision loss. Now, that's something that the rheumatologist is often going to refer the patient to the eye doctor for, is to check on that retinal toxicity, specifically in the macula. It doesn't always happen, but it's something to watch out for. It still happens. So that's something that we want to make sure we get good from them, is a good history of medications, past procedures. Do they use contacts or not? Of course, again, the pain. Is it because of light? Is it painful all the time? Is it only painful with light? Does it feel gritty or like a foreign body sensation? Grittiness and itchiness. That could even just be simple as dry eye. It doesn't mean that there's something in the eye, but they can come in and say, my eye just feels so gritty, so itchy, so irritated. That could just be dryness, but it could also be after they were cutting the grass and something flew into their eye. So again, that history. So important. You need to find out what they were doing, when it happened, how long it's been happening, any activities that they were, partaking in, if it makes it better or worse. Again, that history is so important. I know you guys know that, but I can't hone in on it enough. The history will give you everything. Now, again, history continued, our vision loss. Was it gradual or was it sudden? Gradual could be again cataracts. It's been years that their vision's been getting worse and worse and worse. Was it sudden? That could be a retinal detachment. And again, that changes our severity of the patient, how we're triaging them when we need to see them. Was it partial blindness, complete blindness, night blindness? Again, cataracts leads to the light blindness. Pain. Is it acute angle closure glaucoma? Again, remember you're gonna have pain, the fixed mid-dilated pupil, the cornea is gonna look steamy. So Again, history, can't stress it enough, so important. Your exam always begin with visual acuity. You have to test how they're seeing. Best corrected, you want to test for, how are you seeing with glasses, without glasses, with contacts, etc. You really want to have a good exam when they get in there. The only time you don't do it, as this bullet says, is a chemical exposure. At that point, screw the vision. You want to really get that chemical out of the eye. So you really want to flush it out good. Make sure that irritant, that chemical is no longer burning their eye because the further it burns, the more tissue damage you have, the worse visual outcome you'll have afterwards. So chemical exposure is the only time that you want to make sure you're just getting the contaminant out. Don't worry about the vision until afterwards. The way that we do an examination, we have different letters here that we use to designate different eyes. The right eye is going to be OD, the left eye is OS, and both of them are called OU. I don't know where it came from. It's just what they do, but we talk about it every day. That's just how you designate OD, OS, OU. And if you're talking about each eye individually, usually they're going to talk about the OD first. So, for example, when my supervising physician asks me about a pressure and I say 18, 19, she always knows I'm saying right eye first, then left eye. Again, your exam with and without correction, near versus far. If they can't see quite well, you can do something called a pinhole. It's a little device that we put in front of their eyes, and it just has literal pinholes, but that gets rid of the refractive errors, and it gives us the best possible vision because it just gives one little beam of light back to the macula. So it doesn't worry about that refractive error and the scattering of that light because of the cornea and the lens. The pinhole just gives us our best possible vision. You also want to check, of course, their color vision and also their depth perception. We have different little books and devices that we can use to test how good people's depth is. Visual acuity, our Snellen chart is our distance, the Rosenbaum is our close. We record it just in the chart. We'll say, for example, the Snellen chart for the distance, 2020. So those numbers, a lot of people don't know what they mean. 2020 is our standard. That's our what we call perfect vision. That means that you see at 20 feet what a standard person would see at 20 feet. If your vision is 2025, that means you have to be at 20 feet to see what the standard person sees from 25 feet away, meaning your vision's worse. You have to be up close. If you have 2,300, almost off the chart, that's like the big E. That's all you can see, 2,300. That means you're seeing from only 20 feet away what the normal person can see from 300 feet away. So again, that's what the 20 dash numbers mean. So 20 feet is our standard. 2020 means that you are seeing everything that a normal person would. That's perfect vision. 2030, 2040, 2100. As you go up with that second number, that means your vision is getting worse and worse and worse. In children or patients who are illiterate, you could use numbers, you could use symbols, you could use the letter E in different positions. We call this the tumbling E. I had this just the other day, a patient who had a stroke who understands things, but he has expressive aphasia. He can't talk back to me. So he was a post-op patient after cataract surgery, and every time I saw him, I had to test his vision. He can't tell me what the letters are on a row up there. So I'll just put an E, and I'll, of course, make it the correct size that I want it to do. I'll test it up at 20/100, 20/80, 20/70. I'll get smaller and smaller to see how good his vision's doing, but I'll just have him point with his thumb which way the E is facing, up or left or right or down. So that's another way that you can help get through to your patients and have a proper exam, even if they're, illiterate or don't understand, even if they can't even speak your language. You could always do a tumbling E and have them point which way the E is going. So again, Snellen for distance, Rosenbaum is your up close, and they have what's called Jaeger points, and the Jaeger just correlates to different visions. So you can see, like, for example, J1 is equivalent to, it's blurry on here, but J1 is like 2025. J1 plus is 2020, and it has it on the card. You don't have to remember something like that. But the Rosenbaum is for close, the Snellen is for far, and it has all of your visions that it's worth over there on the side. Again, the eye exam continued, your visual fields, your gross versus formal testing. Your gross testing is going to be, for example, uh, just putting your fingers up in their peripheral vision. Can you see how many fingers are over here, over here, over here? Your formal testing is going to be something like your visual field machine, where we really go down to a science about how far out the visual field can go. And the visual field in conditions like glaucoma is often lost silently. They don't even realize that they're losing their visual field. Glaucoma is going to cause what's kind of like a tunnel vision. They're going to lose it from the outside in. Macular degeneration, remember, goes from the inside out. But we want to have different types of testing. Your Amsler grid used in macular degeneration. That's something that the patients can do at home. It's just a big grid of straight vertical and horizontal lines. If you start to see breaks or waviness or changes or loss of those lines, then you know something's going on in the macula. There's some type of distortion in the macula that's distorting those lines. So again, here you're gross testing visual field by confrontation. You want to see how close they can see your hands. So they should have some peripheral vision kind of out to the side and back a little bit. But if they can only see if you follow my cursor, if they can only see your fingers when it's over here, clearly they've lost all this vision here. So this is just a quick way of testing to see if they're missing vision or not. But you really need to have some finite testing with measurable results that doesn't have any variation between technicians or practitioners. That's why it's not very exact. It's user dependent. Formal testing, like our Humphrey Field Analyzer, this is called a visual field machine. They look into this machine, it's like a big bowl, and anytime they see a flashing light all throughout the bowl, they'll click a little button, and it tells us where they may or may not be missing vision. Now, the eye exam, looking at our pupils, we want to, of course, see the size, the shape, the reactivity. Remember, we talked about anisocoria. Up to 25% of the population may have this just while, as they were born, but it can be from different conditions as well. It's caused by a sympathetic parasympathetic imbalance. And when you do see something this drastic, you want to really start to look into it. The pupillary reaction to the light, we want to see direct and consensual responses. That means when you point the light right at the eye, it should constrict, get smaller, so it lets less light in. That's our direct response. But you should have a consensual response of the other eye. So when you shine it at one, the other one should also be reacting the same way. And of course, that's one of our tests that we're going to use for a lot of other different conditions, like the Argyll-Robertson pupil, for example. Convergence, this is when the eyes are moving inwards towards each other to see objects at different distances. So for a far away target, your angle is going to be much more slim here because the eyes are focusing on quite a far away target. But if it's right up on top of you, you have to almost go cross-eyed and you don't even realize that you're doing it. It's not this noticeable as in the picture. But when you want to look up close, your eyes are going to converge on each other and look at that closer object. One thing that a lot of people talk about, for example, when they're reading and they come in and talk to me, is they'll say that their eyes feel so dry, so fatigued after they read for, 15 minutes, for example. So we have what's called like a 15-15-15 or a 20-20-20 rule. It depends on who you're talking to. But we say about every 20 minutes, every 15 minutes, take a little break for about 15 seconds. Close the eyes, look at something farther away, and that's to allow these muscles to relax. Because if you're reading for just hours at a time, your eyes are going to get locked in here and their muscles are going to just spasm and stay locked in. But if you give them a break every couple minutes, look at something farther away, like you see the angles over here, it just allows for more motion in the muscles, a little more fluidity, and a little more comfort. So that's just something we tell the patients if they're going to be focusing on something for a lot, studying, reading, look at the computer. We tell them every few minutes, take a break, give the eye muscles a little chance to relax, and just kind of hang out for a minute and then go back to it. Now, of course, we have our extraocular muscles. We have a corneal reflex. I know you guys have talked about that in things like PD lab, maybe, where you're going to wisp a little cotton wisp, a little cottontail kind of across the cornea, and it should be quite sensitive. But if you're going to have something like dry eye, for example, a lot of people scoff at dry eye and say it's not really a big deal, but prolonged dry eye will have damage to the corneal nerves, and your corneal reflex can be decreased. You're not even going to feel someone touching it. And when your corneal reflex is decreased, you're more at risk for things like infections, ulcers, bacterial growths, etc., because you're not going to feel those infections and ulcers eating away at the eye because your corneal nerves are damaged. And again, that's from something as simple as just dry eye. And dry eye is very, very common in the population. It's most common in postmenopausal females. Nobody really knows why. It's just something that happens with the hormones and the age. Postmenopausal females are going to be your biggest population for dry eyes. Just like I'm sure you've talked about, or maybe not yet, but you'll talk about it in OB a little bit. A lot of times they have vaginal dryness. It's just because everything's drying out in those postmenopausal females. The eyes dry out just the same. Now, of course, you want to also check for things like strabismus, which is when the eye muscles are a little bit imbalanced. The cardinal fields of gaze. So again, corneal reflex tests V1 and cranial nerve 7. You're seeing if you could feel it or if you want to move away from it. I guess he has a little cotton wisp. Sometimes this is actually a big cotton wisp. We like to even make it a little thinner sometimes when we're testing. So of course you can have your 6 cardinal movements, your eye alignment test, and the corneal light reflection and the cover test. Now, this is going for your strabismus. Strabismus is when the eye muscles are not aligned properly with each other. The cover uncover test. It doesn't say cover uncover here, but the cover uncover test. I want you to make a note of this. Listen in if you weren't listening before. The cover uncover test is the most sensitive test for diagnosing strabismus. That's something you need to know. I want you to put a star. The cover uncover test is the most sensitive for strabismus. Now, strabismus can be treated with just glasses, like for example, prism glasses, or even with surgery. But again, cover uncover test is the most sensitive test for diagnosing strabismus. The corneal light reflection, that's just an easy, quick way to look. But if you're really looking for the board answer, the cover uncover test, that's your most sensitive test for diagnosing strabismus. So here we have our corneal light reflex. You're just holding a pen light in front of them, right in front of the nasal bridge from a few inches out, 18 inches. The reflection should be in the same spot. This is called the Hirschberg test. The Hirschberg test shows you a difference in the light on their eyes. So you can see that this kid here has esotropia, the eyes pointing inwards nasally. And you can see that the light reflection is more so between the pupil and the iris. The left eye is right in the middle of the pupil. Again, the pupil just being the hole, but you can see that the light is not lined up properly. That's because the eyes are not lined up properly. And of course, anyone could look at this kid and say, wow, you're cross-eyed. But sometimes it's much more subtle, and that's why we still do our testing. The reflection should be centered on each cornea in the middle. But again, remember, this is just showing you the Hirschberg test. The big thing, though, like we said on the last slide, the cover uncover test, that is the most sensitive for diagnosing strabismus, not the Hirschberg test, which we see here. The cover uncover is our most sensitive. Okay, examining the anterior chamber, it's pretty limited without a slit lamp. Now, of course, this is not in a slit lamp, but you can see the blood filling up here. This is your hyphema. This is your hypopyon. That's the white blood cells pooling in here. If it gets to be this big, it's prominent. But sometimes you really can't see it unless you're up at the slit lamp. And you want to just shine lights at different angles to see all these things in the anterior chamber. When you use a really thin beam from your slit lamp, it's the slit lamp is just a big microscope with a light. But if you make your light a really thin beam and you shine it across the cornea obliquely, you could see white blood cells probably floating all through his anterior chamber right here. All through it. Now, of course, that's very prominent, but the cells, the floating white blood cells, those you're not going to see without the slit lamp. And again, your hypopyon is the white blood cells collecting. Your hyphema is the blood collecting. We're almost done. Okay, your external ocular exam. Of course, you want to inspect the external structures, your lids, your lashes, the lacrimal apparatus, check for moisture and discharge coming out of the eyes. The color, is there sclera jaundiced? Remember the sclera is the white part of the eye. Is it jaundiced? Yellow. Does it have a melanoma? A big honking uh pterygium, for example, which we see here in the growths or xanthelasmas. You want to inspect your conjunctiva. Is it red? Is it conjunctivitis? Remember the inflammation, the redness of the conjunctiva is conjunctivitis. So is it erythematous? Is it hemorrhaging? Is it injected? That's just when the injection is just the redness. Cornea, of course, any opacities, any scars, any foreign bodies. For example, welders, do they have that flash burn of the cornea that you're going to see, which we'll talk about later, but a flash burn of the cornea from welding without their proper safety equipment. Someone who's in a metal shop, were they angle grinding? Did something fly into their eye? Were they doing outside work? Did they get something stuck in the cornea? Did they get something stuck up under the eyelid? So sometimes you have to flip the eyelid inside out to check and make sure that there's no foreign bodies up under the eyelid. Because if there's a foreign body stuck up under the eyelid, that's going to continually scratch the cornea every time they blink. Every time they close the eyes, another scratch, another scratch, another scratch. So that's really bothersome to them. And sometimes it could be as small as a little grain of sand, but it can really get stuck in the conjunctiva under the lid and really scratch the surface of the eye. Remember, like we talked about earlier, the most common scratched part of the eye with a corneal abrasion is the epithelium. I just want to recircle back to that. The epithelium, most commonly injured spot. So your tools, your ophthalmoscope, looking through the anterior and posterior chamber into the vitreous. You're trying to look towards the retina. You can see your red reflex on the retina, your optic disc, your macula, your vessels. I gotta be honest with you, we never use the ophthalmoscope in the office. The slit lamp exam and using different lenses in our fingers, we have different lenses, like a 90 diopter lens, for example, that goes way more in depth in looking into the eye than the ophthalmoscope. We have them. I've been at my specific job now for about 16 months or so. We have not used it one time, the ophthalmoscope. Tonometer is going to check your pressure. Remember, it's 10 to 20 plus or minus 2. So that's why I usually say like 8 to 22. You have the puff, which everyone, of course, knows about. Everyone dreads it. Everyone always asks us about it, but that's not the most accurate. Your most accurate is going to be your applanation. Okay. The ophthalmoscope. Of course, you want to make sure you dilate. So when you guys are using the ophthalmoscope in PD lab, you're not dilating each other. I never saw anything in PD lab, even though you, of course, want to know what you're looking for. If you're not dilated, you're not going to see jack. Okay. You want to make sure the room's nice and dark, get that pupil big. You're going to use dilation drops. Usually it's 1% tropicamide and 2.5% phenylephrine. This these words here, they kind of scrunched here, but this is 2.5%, not 25. Tropicamide 1%, phenylephrine 2.5%. We're not going to be asking you medications like that, but just keep it in mind, you really need to dilate the pupil, keep the room dark if you have any hope of using the ophthalmoscope to see things. Now, of course, I have a slit lamp in the office all the time. Every single room has a slit lamp. It's not an ophthalmology office without that. But if you're in the ER, you're in an ENT rotation, you're in a pediatric office, you're probably not going to have a slit lamp. So that's where the ophthalmoscope is still useful, is that kind of primary screening tool. But you don't have a snowball's chance in hell of seeing anything if the pupil is not dilated. So don't be discouraged or feel bad about yourself if you can't see it. It's because you're not dilating each other. The room is not dark when you're doing it. You really need that to see anything with the ophthalmoscope. Cyclopentolate 1%, a little bit longer acting, dilates the pupil longer and larger, but again, we don't really use that as much. Our normal dilations is these two drops. Just clinical points, nothing too crazy for your knowledge. Slit lamp exam, again, this is what it looks like. It's a big microscope, and the light comes down from here, bounces off a 45-degree angle mirror and into their eyes. And when I'm looking through the microscope part, past the little mirror and seeing where the light is landing and looking into their, of course, eyeball. So it gives you a magnified 3D view of the cornea, the AC, the lens, the vitreous, and it can also measure the IOP. We have a Goldman applanation tip that swings around on here. And again, that applanation is the most accurate way of measuring pressure. Woods lamp, this is going to be kind of your looking for corneal abrasions, your foreign bodies. We don't really use this either in the office because the slit lamp has different colored lights in it. So we have just a regular white light, but we also have a cobalt blue light that supplements our Woods lamp. Of course, it's less sensitive than a real slit lamp exam, uses UV lights. You're going to want to use some tetracaine to numb the eye and some fluorescein dye. The fluorescein will uptake into any areas of damage and allow you to see anything that's going wrong. Again, abnormalities will glow under the Woods lamp if you put the fluorescein dye. But we don't ever use this in my office because, again, the slit lamp covers us. Fluorescein, we have little strips like this. They also have it in a dropper form. I personally like the fluorescein strips better because it's not quite so goopy and overpowering. If you put the drops into their eyes, sometimes it's just a little overpowering. You can't really see past the fluorescein for a little while. But again, here, this is what we would call uh, punctate epithelial erosions or superficial punctate keratitis. This is just a symptom of dry eye. So this is when the eye is all dry. It's making little micro ulcerations all over here. And when you put the fluorescein in and use your certain color light to see it, your cobalt blue light, it's going to fluoresce everywhere that stain uptook. So, for example, if you had a big corneal abrasion, it would be a big linear streak, and you would see that glowing when you do the fluorescein and the light. Again, we talked about this earlier, lid aversion. You want to make sure that you're looking up underneath it to see if there's any foreign bodies. I usually like to use a Q-tip, just like this shows. You have them look down towards their feet. You grab them by the eyelashes. You grab a bunch, not just one eyelash, otherwise you'll pull it out, but you grab a bunch of eyelashes with your fingers, and then you just flip up and around the cotton swab. Tonometry, of course, this is how we're measuring pressure. This is what we call the tono pen, and you're just tapping on the eyeball. You have little tono pen covers, kind of looks like a condom. You roll it on just like that, and it allows you to use this on multiple people without an infection risk because you can switch out the tip every single time with that little cover there. So remember, whenever you're tapping strangers, use protection on your tono pen. Your Goldman applanation tip, again, this is, of course, our slit lamp that I was telling you, and it's a little prism here that we use to check pressure. This is our gold standard of pressure testing. The way that we're getting the pressure is we're seeing how much pressure it takes to flatten one spot in the cornea, and that pressure to flatten the cornea is dictated by how much fluid, aqueous humor, is pushing outwards on the cornea. So that's why it's kind of a give and take with that fluid. You want to make sure you have a good inflow, a good creation versus good outflow of fluid, and that's what we're measuring. Morgan lens, this is something that you can use after you have a chemical exposure. You put it right onto the eye, kind of like a contact, and you can just keep using syringes to keep flushing the eye, flushing the eye. You can even do it from a saline bag and a drip. Sometimes we can just flush out the eye with just purified water bottles. But again, you want to make sure you use a nice clean water to flush out the eye, not introducing more contaminants. And that's it. So that's the end of lecture one. Do you guys have any questions? Okay, well, I'll hang out for a second. If you guys do have any questions, feel free to unmute. Remember, you could always email me any questions you may have, and I'll see you guys. I think it's next Tuesday again for our second lecture. I'll make sure that you guys have the slides before we do that. You guys have any questions?